Hi everyone, I'm Paul Orfanos, National Community Engagement Manager at Delphi Bank, which is a division of the Bendigo Adelaide Group, and welcome to Delphi Connect, a segment where we, as part of our commitment to community engagement, interview and bring to you leading experts from fields as far and wide as economics and the markets, property, health, scientific research, the arts, community affairs, just to name a few. Hopefully you'll find our segments both informative and enjoyable. Let's move straight on to today's guest, Associate Professor Arthur Nasis, who's a consultant cardiologist and cardiac imaging specialist. He's the Director of Acute Cardiac Services at MonashHeart, Victoria's largest cardiovascular service provider. Arthur, welcome to our segment.
Thank you, Paul. Thanks for having me.
How has the Monash Medical Centre been handling COVID-19 pandemic?
It's certainly been a very large operation, Paul, something we've never really faced before. We've really had to put everything else, not aside, but sort of to the back burner and really focus our energies on getting ready for what was potentially going to be a large surge of patients. And that certainly took up a lot of our time and our preparation. But thanks to the excellent work done by our policymakers and by the people in adhering to social distancing and the various other measures put in place, that surge didn't come. And as a result, we've now been working on slowly increasing the things like the elective surgery that's been postponed. So, it's been a balance for our health service, but it's one that so far we're handling admirably, I think, and has led to minimal morbidity in the community as a result. So it's certainly been difficult, but it's going well so far.
And that's great to hear. Arthur, when discussions turn to health, it's not long before the heart's discussed, and many people talk about this hardening of the arteries. What do we mean when we talk about hardening of the arteries?
So arteries, Paul, are the pipes that sit on our heart muscle, and they basically deliver the muscle blood so it can work. So it can pump blood to the rest of the body. So the heart itself needs blood. And those arteries can become hard, and hardening just basically means that the walls of the arteries can develop buildup of fat or fatty lipid or cholesterol or calcium. And that's basically a process that evolves over many, many years. In fact, we see early hardening as early as teenage years in some people, and that can progress over the years and decades to completely block the blood flow through the artery. So, and that's obviously quite a difficult event to encounter and manage, because that's what leads to heart attacks. So hardening of the arteries is really the process by which the arteries that supply blood to the heart become narrow and eventually block due to various factors.
Much has been done through the decades to help people stop smoking. What is that link between smoking and heart disease?
It's a very clear link, actually, and really one of the things that we can do a lot about to reduce the risk of heart disease. So smoking is one of the main contributors of this hardening of the arteries that you've alluded to, Paul. So smoking leads to the buildup of calcium and hardening of the arteries that can eventually lead to narrowings and blockages, and it's certainly a big contributor of that. And that, of course, does lead to shorter life expectancy, can lead to weakening with the heart muscle, and it can lead to various other adverse outcomes. So that's the link between smoking and heart disease.
Thanks for that. We hear, Arthur, of various risk factors being attributed to coronary artery disease. Can you please explain these risk factors, and what should someone do if they have some of these risk factors?
So, Paul, really it's worth dividing these into modifiable and non-modifiable risk factors, because the modifiable are in our hands and we can do something about them. Firstly, the non-modifiable risk factors for coronary heart disease are gender, so males are more likely to develop heart disease than females. Age, so the older we get, the more likely we are to develop heart disease. In fact, a 40-year-old male in our society has a 1 in 2 chance of having coronary heart disease in their lifetime, and a 40-year-old female has a 1 in 3 chance. So the older we get, the more likely that is to develop. And then we have the modifiable risk factors. Now, these are things that we can do something about. Now, you've already touched on smoking, which is a big one. Another one is high cholesterol. So high cholesterol leads to increased risk of this fatty plaque being deposited in the blood and in the arteries of the heart as well. We have high blood pressure, which is the third modifiable risk factor. And we have diabetes as well, which is an increased level of circulating sugar, which can also contribute to build-up and hardening of the arteries. So they're the modifiable risk factors. Now, the other non-modifiable one that I mentioned, which we can touch on further later, is family history and genetics, because there is a very clear link between your first-degree relative risk of heart disease and your risk of heart disease, especially if that index event in your first-degree relative was before the age of 65.
Interesting to note. At this stage of the segment, I'd like to quickly share a story. We don't often get messages to the effect of "thanks, you've helped save my life," but to our surprise, we did last year. And it was from a customer who had come along to listen to Arthur present at a Delphi Bank business breakfast. And after listening to the presentation, he went for a checkup and had to have an emergency heart procedure shortly after. And I'm glad to say he's now well. And I've mentioned this story as a prelude to the very important next question. What symptoms, Arthur, are usually attributed to heart disease?
Yeah, really important, Paul. So look, there's a few, and there are different types of heart disease that are associated with different symptoms. So if we talk about coronary heart disease, which is the most common cause of heart disease that often leads to death, the number one symptom to be aware of is chest pain or chest tightness or chest heaviness or chest discomfort. And classically, that symptom comes on with exertion and is relieved with rest. So your classical textbook story might be somebody who goes for a jog or for a brisk walk, or they're running to catch the train, and they notice that their chest tightens up. And as soon as they slow down, that goes away. So that's a pretty telling symptom that would make us really worried of coronary heart disease. But having said that, it doesn't always have to be that sort of classical chest pain. Sometimes the pain can be felt up in the neck, in the jaw, in the teeth. Sometimes it can radiate down the left arm, possibly sometimes even through to the back. So discomfort in the upper chest and surrounding areas is the main one. But beyond that, shortness of breath is another one. So there are lots of reasons why someone might get short of breath beyond the heart, but it's certainly a very common cause of coronary artery disease, and in fact other types of heart disease as well, like weakening of the heart muscle and build-up of fluid in the lungs. So shortness of breath is another key symptom, and sometimes that shortness of breath, if it's associated and due to heart disease, can be associated with difficulty lying flat in bed. So, for example, people might find that they have to prop themselves up on 2 or 3 pillows to actually sleep, or occasionally they might wake up at night with gasping for breath. And that's because a weak heart muscle can lead to fluid accumulating in the lungs when people are lying flat. That can lead to those symptoms. Another thing that can be associated with shortness of breath due to heart disease is bloating of the stomach or the abdomen, and also swelling of the legs and the ankles. So there are other symptoms. And then, of course, another common type of heart disease that we see in our community is arrhythmia, or atrial fibrillation is the most common type of arrhythmia. And the symptoms to look out for there would be palpitations, or people noticing their heart skipping a beat or beating irregularly. And that can be associated with lightheadedness or dizziness as well. So they're the sort of key symptoms to look out for. And again, as I mentioned, I mean, they often are associated with heart disease, but there can be other causes as well. But they're certainly symptoms that should not be ignored. And what I say to everybody when I talk about these things is, if you're not sure, just get it checked out. There's nothing better than a false alarm. And I think, as doctors, we'd much rather reassure people that their symptoms are not due to anything serious than the opposite, which is people ignoring symptoms that do turn out to be difficult down the track. So they're the main symptoms of heart disease, Paul.
It's very, very interesting and very useful information there, Arthur. Just on the diet now, let's just change a discussion to diet. It's been said that eating a good diet is a powerful way to reduce some heart disease factors. What dietary changes can people make to reduce their heart disease risk? And I suppose what may interest some people is, can red wine or dark chocolate be included in a healthy diet?
Yeah, so it's a diet is an important factor in heart disease risk, no doubt. And what I'd suggest to people watching this is, I think groups like the Heart Foundation have some fantastic resources where you can print off some very basic sheets and food pyramids that can actually give you some idea about what sort of diet you should eat. But the principles really centre around avoiding saturated fats, fried foods, sweets, carbohydrate, diet high in carbohydrates, especially white carbohydrates rather than whole grains, and really minimising calorie dense food like and alcohol is one of those, in fact. The other thing to be aware of with diet is that really fibre plays an important part in reducing risk of heart disease, and they're the key elements really around diet. You touched on alcohol. Look, the jury's really out on alcohol. If you look at the studies, a small ingestion or consumption of red wine a day does reduce your risk of coronary heart disease. But if you look at the overall risk of all health problems associated with any alcohol consumption compared to none, the outcomes are worse. So that's why the World Health Organization recommends that the safest level of alcohol consumption is 0. But if you are looking specifically to lower your coronary heart disease risk at the expense of potentially other problems, then a small amount of red wine per day will help. And regarding your question about dark chocolate, again, dark chocolate has some compounds and antioxidants that are believed to increase your good cholesterol. But again, the jury's out there, Paul. There haven't been any large trials comparing people who have a lot of dark chocolate compared to none. But what I would say is for the sweet tooths out there, that's certainly probably one of your best sources of sweets rather than other types of sweets.
Food packaging, Arthur, contains a lot of information on the nutritional value of its contents. We hear about cholesterol, low cholesterol or no cholesterol. Is cholesterol totally to be avoided?
It's a tricky question. I think in general the answer is it's important to try and minimise high cholesterol foods. Most of the cholesterol level in our body actually is made up by our own body, by our liver, and that's genetically programmed. So the majority of cholesterol is in fact made up from that portion. Probably about 15 to 20% comes from what you ingest, and cholesterol-rich foods like again the saturated fats that I mentioned, butters and the like, can increase cholesterol, particularly bad cholesterol and triglycerides. So, as I said, those foods should be minimised in most people, especially those that increase risk of heart disease, or people who already have a high cholesterol. But the other thing I'd like to touch on food packaging beyond cholesterol, because a food package won't specifically tell you the cholesterol level in the food, but it will tell you the calories and the amount of fat and protein and carbohydrate. But the other thing that is important to look for is in fact the salt or sodium content, because I touched on blood pressure before, or high blood pressure being a risk factor for heart disease, and there's a very clear link between excessive sodium or salt consumption and high blood pressure. So for people who have high blood pressure or are taking high blood pressure tablets to control their blood pressure, they really should look at the salt content and really try and minimise that as much as possible, and that is clearly labelled on foods.
Very interesting information. Arthur, you alluded to this before, but I'd just like you to elaborate a bit more. Some in our community believe that heart disease predominantly afflicts males. You did mention some statistics before, but how common are heart diseases amongst women?
Yeah, look, it's very common, Paul. So heart disease affects both genders. Males are more likely to get heart disease than women, but heart disease is still the most common cause of death in females in the Western world as well. And in fact, females are 3 times more likely to die of heart disease than of breast cancer. And that's a fact that is not widely appreciated. And that is why, regardless of whether you're a male or female, you really need to pay attention to your heart disease risk to really keep that in check. And the other specific thing about females is females tend to not present with the classical heart symptoms that males can. So, for example, females with narrowings in their arteries or coronary artery disease don't always necessarily present with classical chest pain. They can have more atypical pain than males. They can present with more shortness of breath, and it can be harder to diagnose. So we really need to have a higher index of suspicion in females compared to males as well. So it's common, and it can be harder to diagnose. So really there should be no real differentiation between males and females.
Very interesting statistics there. From time to time we hear of new developments in the health field. What advancements, Arthur, in cardiology has you most excited?
Oh, look, there's so much in cardiology. So what we're seeing more and more of is that in cardiology, and in fact in health in general, we're generally seeing older patient population with more complex comorbidities or more complex health problems, which can make it higher risk to deliver specific treatments like operations. So in cardiology now, we're moving into less invasive or minimally invasive procedures where in the past we couldn't do. So one that's really improved in the last 5 or 6 years has been what we call transcatheter aortic valve replacement. So something we haven't spoken about today is narrowing of one of the heart valves, which again is something that's more common in older people. Up until about 5 or 6 years ago, the only way that we could fix a severely narrowed heart valve would be to open up someone's chest, open heart surgery, take it out, put the new one in, re-sew the sternum, re-sew the chest, and that's at least sort of 5 or 7 days in hospital, and a recovery that can be up to 6 months in some people. Now it can all be done by delivering the valve via an artery and a vein in the leg, which goes up to the heart with no big cut, no big anaesthetics, where patients can get up and walk around within a day and be out of hospital in 2 or 3 days. And that's something that we're seeing more and more of, and data is showing that the outcomes of these patients are good. The other real advance in cardiology that's got me excited and I think has made our job easier is less invasive and more accurate investigation tools for diagnosing coronary heart disease. So we now have CAT scans of the heart, or CT angiography, which is a test that can take a picture of the arteries to show us if there are any narrowings or blockages there, which is minimally, well, non-invasive really. There's no risk. Again, a new technology that sort of 5 or 7 years ago had to be done by instrumenting the artery directly via the leg and passing the catheters up to the heart itself. So really we're moving into less invasive investigation, less invasive management of various conditions. And as we're going on, I think we'll see more and more of that.
Now, a bit of crystal ball gazing, Arthur. Where do you think cardiology will be in 20 years' time?
Yeah, look, it's interesting. I think where it needs to go, Paul, I think we need to shift as much as possible into prevention. So I think all the risk factors we've spoken about today, not all, but the majority of them are preventable. Okay, so if we do the right things in terms of doing the right things in terms of lifestyle, doing the right things in terms of being in contact with our doctors so they're picked up early and we put on the right preventative treatments, then I think that there's a very good chance that the rates of things like heart attacks and strokes and arrhythmias will be much lower in the future. So where I'd like to see cardiology go is into a bigger shift towards prevention. And I think that will be possible as our tools to diagnose it earlier get better, and as our tools to predict who develops heart disease gets better. So we know that there's genetic links in heart disease amongst our first degree relatives, but we don't know exactly what those links are, and we don't know exactly what the genes are or what the groups of genes are. And I think genomic and personalised medicine as we go forward will play a bigger role for sure. And the other thing that I think is if I crystal ball and crystal gaze even further, it's not beyond the realms of something that I may see in my career. We will be able to give people injections, to lower their cholesterols, and that lowering of cholesterol may last sort of 6 to 12 months, almost like an immunisation, because we do have some medications that can do that already in selected people. And it may be that one day when we get to the age of 30 or 35, we have this injection every year. Lowers our cholesterol by 70 or 80%, which we know is associated with a much lower risk of heart attack. So I think while we're getting pretty good at treating heart disease, where I think and I hope things go is preventing heart disease, because, as I say, prevention is always better than cure. And I think we need to focus our attention there, and that's certainly something I hope we'll see.
Prevention is always better, Arthur. I certainly agree. Thank you for making time to share your specialist knowledge with us today. Your insights are always very much appreciated. That's all for today's segment of Delphi Connect. On behalf of all of us at Delphi Bank, thanks for joining us, and bye for now.